Okay, I'm going to start, Sister Ren. I think next time we'll do it like official, because there is no point of this way. You are two here, and we can assess and go. So in the first session, we've talked about the purpose, the anticipation of resuscitation, the training, and the high delivery. And then we talked about the fetal conditions or the high risk delivery, which means that delivery that we might expect that this baby will need help more than the like the routine help. And we've talked also about the challenges that the fetus might expose to, such as hypothermia, inadequate ventilation, infection, and organ damage. We've talked about the equipment and the check and how we should start oxygen, how to do the pre-wound, how to avoid infection and organ damage, and also hypothermia. Today we'll be talking about the antenatal counseling. So the ideal situation that a physician should go and meet with parents and discuss with them all the expected complications and the chance of survival of their babies, in addition the duration of admission, the financial consequences, and the and they can answer their questions. And this should happen for all babies that are expected to deliver after 33 weeks. And there are, it would be wonderful if we can provide these parents with a written piece of information to tell them exactly what they are expecting. For those below 22 weeks, the current survival would be 0. Those who are above 23 weeks, they have some chance of survival, and then depend on other factors such as the weight, the delivery condition, the risk of infection, and so on, you know, singleton or multipara. These conditions might add to the percentages of increase or decrease in the survival rate. And ideally should be involved the obstetrician, the neonatologist, and probably one of the nurses with the parent. And the ideal situation should be both parents are available for such discussion, and then we give them a piece of information and they can read and they can ask questions later. This approach would decrease the complaint and increase collaboration and the compliance with the orders and with the expectation. And so what are the initial steps of ventilation? And these are from the first algorithm of the NRP. Although there are other programs equivalent to NRP that might be used for resuscitation. So what are the initial steps of resuscitation? The first step, and these initial steps should be administered to all newborn babies regardless their condition, which is keeping the baby warm, and the baby can be kept warm using warm mattresses, pre-warmed room, using the skin of the mother, cover, using incubator, and so on. So you need warm, and also to maintain the body temperature. Position airway, position the body in a way that all the airways, upper airways, are aligned together for better ventilation. And also, if there is a secretion, need to be cleaned. The baby should be dried and stimulated. Now, stimulation is a big problem as there are many traditions, movies showing false way of ventilation. The ventilation should be initiated after birth, and it should be only tactile. Now, the ventilation should be not prolonged. If the baby tactile stimulation is not improving the breathing and the general condition of the baby within 30 seconds, then further tactile stimulation would be futile, and the baby should go to the next step, which is providing ventilation. Again, when we do the tactile stimulation, should be only stroking the palm or the sole, maybe rubbing smoothly the back, and that's all. The head of the baby should be always kept above the body or at the same. Holding the baby from the leg will not help, and it could cause a permanent back pain all the life. And it will not improve the ventilation. Hitting the baby on the back is inappropriate. Squeezing the abdomen and the organ is inappropriate. So the only gentle stroking, and that if that won't help, force and rude type of stimulation will not help. So these are important that everybody knows. Holding the baby from the leg, whether obstetrician or a neonatologist. Holding the body above the head will not help. Always the head needs to be supported, and the tactile stimulation should be simple and should not exceed 30 seconds. We need to dry and suction. Now, suctioning only the upper airway. Deep suctioning is not. Going to the stomach is wrong, is not necessary, and will not help, and will interfere and might cause further problems such as stimulating the vagus nerve, causing bradycardia, causing upper airway injury, and also might delay the breathing. So, and we're taking a valid nutrition from the stomach. So no need, even if there is meconium, no need for deep suction, only if it's obstructing the upper airway. And gentle and smooth, and only the mouth and the nose. No need to go further more than the nasal or oropharynx. The stimulation, as we said, is brief and smooth and gentle. Slapping or flicking the sole. So slapping means hitting the sole and the palm by all the finger, or flicking by one finger, rubbing the bag smoothly, not anymore, no more, anything else is not. Hitting the bag is wrong, squeezing the chest is wrong, adducting the lower leg on the abdomen is wrong, carrying the baby from the leg like a chicken is wrong. Vigorous stimulation will not help, but provide some injury. Now, there are three types of care. There is routine care, and there is monitoring care, and there is intensive care. So who qualified for routine care, which means a care that is provided where the baby with his mom. So all the babies who are born at term, who has a good tone. How we know there is a good tone? The hand and the feet are off the mattress. So the baby can carry the hand and the feet above the mattress. Baby is crying and breathing. There is no need for the baby to cry when we do resuscitation. If the baby is not crying, then there is no need. The baby should be only breathing. And if the baby is breathing, that is enough. How we know the baby is breathing? Sometimes you don't see it. It's very shallow. It's only from the heart rate. If the heart rate is above 100, then everything is fine. You don't need to ventilate. The heart rate above the 100, then, and the tone is good, mean that the baby can carry the hand and the feet off the mattress. So these babies, they can stay with mother, and they can be care as a level 1. When we say routine care, mean providing feeding, establishing the feed, vaccinating, examining the baby by a physician within 24 hours, maybe do circumcision if religiously indicated. So that's called a routine care. Of course, all the babies, even the routine care, deserve a delay cord clamping. The cord clamping should be more than 30 seconds up to 120 seconds. So all the baby deserve delay cord clamping. Then there is further care. And the further care are of two types: monitoring care and intensive care. So any infant who failed the criteria, that means he's not tone, he has poor tone, he's not breathing, no tone, not crying, no breathing, and he's not tone, is deserves a further care. So after the initial step of resuscitation, which is providing one, positioning positioning the baby, stimulation, dryness, and clearing of secretion. These are the initial steps. Any baby who is not meeting this criteria, go to the further care, which means that you need reassessment after 30 seconds. So we assess the respiratory effort, the color, and the heart rate. Because remember, at the beginning, we assess three questions. Is the baby tone? Is the liquor clear? And if the heart rate is more than 100, and if the tone is good. After that, we assess if there is a breathing, how's the color, and how's the heart rate. The heart rate is vital in assessment of the effectiveness of the respiratory effort. So sometimes if you don't see the respiratory effort and your heart rate is okay, and especially if you are connecting a sat monitor and the saturation is okay, there is no need for the baby to cry or show you that he's breathing. If the heart rate is okay, more than 100, then this baby is breathing. Now, how we count the heart rate? The count rate either should be pulse oximetry or ECG monitor, not the pulse oximetry, not by palpating the umbilical cord, not by palpating the heart rate by your hand. The heart rate should be counted only by auscultation and pulse oximetry to look at the oxygenation and using ECG. Now, you have to know that ECG is a reasonable option for rapid and accurate count of the heart rate, not the pulse oximetry. Then we've counted the heart rate. If the heart rate less than 100, look at the infant. If the infant is apneic or gasping. The apnea means baby is not breathing for more than 20 seconds or less than 20 seconds and associate with brady or changing color. Gasping is non-effective breathing. So when there is gasping, the chest is moved, but actually there is no breathing. And the heart rate below 100, then you need to do the following. Not any more stimulation. Stimulation will not be helpful. You need to provide PPV. PPV, 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 and anything else. The most important, you provide not only PPV, but effective PPV, which means there is chest rise and there is air entry. And you have to provide it about 40 to 60 events per minute. And then monitor the pulse oximetry. And when you monitor the pulse oximetry, look at the target. What is your target saturation? And monitor your ECG, which is you need to put 3 probes on the chest, or 2 sometimes. Based on that, you decide the further resuscitation after 15 seconds when you reach at age of 1 minute. If the heart rate is not increasing, please assess if you are providing effective breathing. Effective means there is chest rise and there is air entry. If the chest is not rising, then do the Mr. Soft. So M for mass adjustment, R for repositioning the airway, S suctioning the mouth and the nose, O opening the mouth and tilt the jaw forward and increase the pressure by 5 to 10 centimeters of water. But the maximum you give is 40. And if that not help, then you need an alternative airways, such as laryngeal mask airway or endotracheal intubation or an oral airway. So remember, if you give PPV after 30 seconds and still the heart rate is not okay, go to Mr. SOPA, MRSOPA. No need to stimulate, okay? So remember Mr. SOPA if the heart rate is not going up. If the heart, however, after 30 seconds, the heart rate is increasing, continue PPV and check the heart rate after 15 seconds. If after a total of 30 seconds, you need to assess the heart rate. If the heart rate went above the 100 and the baby starts to have spontaneous respiration, stop PPV. You may give free flow oxygen by your hand, by mask, based on your saturation and target saturation at the graph and the table they provide to you in any labor room. Keep checking the heart rate and saturation and determine if the baby is breathing spontaneously, or whether he needs CPAP or not. If the heart rate is below 100, PPV has to be continued. And chest wall movement has to be improved. And remember, Mr. SOPA. And these are position the mask, reposition of the baby, suction, and open the mouth or jaw, pressure is increased, and or use alternative airways. If the heart rate, however, below 60, whether at 30 seconds or other 1 minute, at 30 seconds, even the heart rate below 60, you have first to provide PPV. If you provide PPV and it's effective PPV, meaning there is chest rise and air entry, but still the heart rate went below 60 at age of 1 minute, you need to think about chest compression. Once you think of chest compression, you need to make sure that the ventilation is effective. And in that situation, you might put laryngeal mask airway or endotracheal tube to make sure that you are ventilating with the chest compression. If you continue the chest compression and the heart rate is still below 60, think of vascular access. And the best one is low-lying umbilical catheter. And because in that situation, you need to give IV epinephrine. If you are intubated and there is no time to do this, then you probably can give the epinephrine intratracheal. Once you have this situation, make sure that the baby is not hypovolemic from the color and from the blood pressure if you can, and from the history of the mom. If there is placenta previa or accreta or there is bleeding, you need to give volume expansion. And remember to give only 10 milligram, a mil per kg over 30 minutes or so. And think of other causes that allow the baby is not improving, such as pneumothorax, hypothermia, hypoglycemia, and so on. If the heart rate more than 100, as here, however, the baby is still labored breathing and persists cyanosis, you might think of giving CPAP. When the heart rate is more than 100 and the breathing is labored, then also think about proper positioning. Look at the saturation. So if the baby has labored breathing, but the saturation is okay, you just need to monitor. The saturation should be checked at pre-ductal. And always consider the positive airway pressure. In a premature baby, the target saturation or the target CPAP should within 2 minutes start. And at a preterm baby, the CPAP centimeter or the pressure can be increased up to 9 or something. But in term baby, you want to be careful because a stiff lung can cause pneumothorax. So more liberal pressure in premature baby less liberal, but you need to be effective CPAP. Okay, I'm going to stop here and we'll start tomorrow from term neonate. Any question?
No, so far, doctor.
Okay, so let's do it official next time, and let's ask them why they are not attending. And anybody attended delivery and not following these lines, I'm gonna write OVR. Why not following, despite we are writing it and presenting it and discussing it, and it's only online, so I don't know why people are not attending. Okay?
Thank you, doctor.
Thank you very much. Okay? Have a good day. Bye-bye.